السلام عليكم ورحمة الله وبركاته. هنبدأ البانل 5. It gives me a great pleasure to be with you today in this honor event. It is my pleasure to introduce Dr. Razat Subki. He will speak about genetic of fetal anomalies, recent advances in diagnosis.
ماشي. مساء الخير عليكم جميعا. I know that somehow you are a little bit exhausted, but I'm really honored to be invited to actively participate in this eminent meeting. I will discuss the genetics of fetal anomalies and especially the recent progress or advances in diagnostics. Simply, you can say that the genetic etiology of fetal anomalies could be structural or functional. Structural could include the skeletal system, the heart, the lung, the limbs, and the function may be related to the function of the brain or inborn errors of metabolism So we'll be mainly speaking about the structural fetal anomalies. This is a skeletal deformity, one of the structural fetal abnormalities. And this is the most common presentation very early, either by increased nuchal thickness or sometimes with cystic hygroma and hydrops. On the other side, you can have encephalocele, but sometimes associated with the encephalocele, you may have a polycystic kidney, and you can also have polydactyly, extra digits, and this is simply, if you see them by ultrasound, then this may indicate the diagnosis of Meckel-Gruber syndrome. So the congenital structural anomalies, actually, it forms like 2 to 4% of all pregnancies. And it could be due to environmental etiology, genetic causes, or multifactorial. And the multifactorial inheritance indicates that there is an interaction between the environment and the background of genetic susceptibility. For the genetic causes of structural fetal anomalies, it could be chromosomal due to cytogenetics or chromosomal abnormalities, and it could be a single gene anomaly, and as we mentioned just now, it could be multifactorial disorder. One of the most common multifactorial inheritance is the neural tube defects, including the anencephaly. And it's quite known that the folic acid deficiency is the environmental factor, but in some families, they do have a genetic susceptibility too. The second multifactorial inheritance is the isolated congenital heart diseases. So simply we can say that to diagnose fetal congenital anomalies, you may need to study the chromosomes, or you can sequence the whole genome, the DNA sequence, and in between the cytogenetic studies and the molecular sequencing, you can have the FISH technique or the chromosomal microarray study. This is simply a karyotype that by offering karyotyping you can detect chromosomal abnormalities. And as we said, that sometimes we go for FISH technique, fluorescent in situ hybridization, to detect a case with multiple congenital anomalies. It could be due to chromosomal abnormalities like trisomy 21, trisomy 18, or trisomy 13. And FISH can diagnose such cases in 24 hours rather than waiting for a culture and more than a week. Sometimes you have apparently normal chromosomes, but you have a very tiny deletion of one of the chromosomes, and this is, we call it micro deletion disorders. One of the most common causes of congenital heart diseases detected prenatally among the fetuses, DiGeorge syndrome. And DiGeorge syndrome, they do have micro deletion of chromosome 22. And if you do FISH on the chromosomes, you can detect simply a missing DiGeorge critical region on one copy of chromosome 22. And having the chromosomes and having the FISH technique, actually the FISH technique, you should have a target with a specific probe. So the use of single nucleotide probes, you can have the chromosomal microarray. And the microarray actually can discover all the microdeletions and any other rearrangement in the chromosomes. And so you can do karyotype, you can do FISH, and even you can do chromosomal microarray to detect any chromosomal abnormalities. And here, when you see the microarray, the chromosomal microarray is added in here between the FISH and the molecular sequencing of the whole genome. This is the chromosomal microarray. And actually, the molecular sequencing, as you know, we have like 3 billion nitrogenous bases making up the whole fetal genome. And to read these 3 billions, it means that you are offering sequencing, the whole genome sequencing, and sometimes we restrict the sequencing to what we call it whole exome sequencing. And this is how to offer sequencing to detect an abnormal mutation or change at the nitrogenous nucleotide basis, even deletion or duplication at the level of nucleotides. And this could be offered nowadays by a technology known as NGS or next generation sequencing. So by offering next generation sequencing, you can detect mutations. And nowadays we call this mutations variants. And that's why you have to classify the detectable variants. And these variants, according to the American College and other American Pathology Association, should be classified into 5 categories. You can have the pathogenic variants, likely pathogenic variants, variant of unknown significance, likely benign and benign. And this is based on several studies, including the population study, the computer analysis, functional data, and segregation analysis. So we can have a time frame for this progress in the technology of diagnostic of genetic disorders of the fetus. We can say that very early in 1970 and 80, the conventional karyotyping or conventional cytogenetics was taking over that time. But then the FISH technique started by 1990 and still we use it. Then the microarray study, and then nowadays taking over the next generation sequencing. So if you see the progress based on the timeline that you can see here from 2002 to 2010 or 11, that the FISH technique was actually the significant technology to sort out some cytogenetic abnormalities. Then the microarray study started, but again declining, and the next generation sequencing is almost taking over nowadays to diagnose almost all types of genetic disorders. So genetics of fetal anomalies could be classified into chromosomal abnormality and single gene anomalies. If you offer karyotyping, chromosomal analysis, actually about 30% of the fetal anomalies, especially if it's multiple congenital anomalies, could be detected by cytogenetics. If you add the chromosomal microarray, the yield will increase about 10% more, so you will have like 40% of congenital fetal anomalies are due to cytogenetic abnormalities. Yet, if you stop at that level of investigations, you are almost missing 60% undiagnosed cases of multiple or single fetal anomalies. And this is actually due to single gene anomalies or monogenic disorders. And these monogenic disorders actually is close to 7,000 detectable diseases. So again, genetic testing could be divided into cytogenetic investigations, including conventional karyotyping, FISH technique, or chromosomal microarray. And if you go to the molecular genetics with the recent progress in the ability to investigate the fetal genome to diagnose the fetal anomalies, you can offer single gene sequencing, Sanger sequencing, panel testing, clinical exome, whole exome sequencing, and whole genome sequencing. If you think about clinically and practically about a fetus with congenital anomalies, then either to go for having a fetal cells, and this is the cellular origin of the DNA, then using the fetal DNA through the fetal cells, you can diagnose anything. But actually, and with the change of concepts of fetal DNA, you can actually have the cell-free DNA. And cell-free DNA actually started by discovering that some of the fetal DNA is actually circulating in the maternal circulation. By isolating the cell-free DNA from the maternal circulation, you can actually study the genetics of the fetus. And using the next generation sequencing, what we call it now NIPT, or non-invasive prenatal testing. That means that you can take a blood sample from a pregnant lady, like by the 10th week of pregnancy, and you can separate the cell-free DNA, amplify this cell-free fetal DNA, and you can study specifically the chromosomes and the microdeletions of this fetus. NIPT, which is a non-invasive prenatal testing, could be offered by blood sample and could be simply for the trisomy, the viable trisomies, and could be, you can add an extra chromosomal testing with a microdeletion panel. So we can summarize that the diagnosis of the multiple congenital anomalies of the fetus by offering non-invasive testing, NIPT, or invasive technique using CVS or amniocentesis. You can just extract the fetal DNA, and even nowadays you can offer fetal whole exome sequencing by invasive or non-invasive technique. And thank you very much.
Thank you, Dr. Isaac.
Thank you very much. Our next talk is Palliative Care in Fetal Medicine by Professor Shurabi Nanda, UK.
Thank you once again for this talk and to the organizers for the kind invite. This is the second time I've come to Cairo and I've thoroughly enjoyed it again this time. So we're in the city of the dead. We're in the country and the city where the death, the departing, and the departed are respected. And you have these are pictures that I took from the museum that I visited a couple of days ago. And you've got gods, you've got people you've got symbols that respect the death and departed, but also the children. So along the same theme is this talk. We've talked about problems in babies. We've talked about hydrops, fetal tumors, fetal abnormalities, but then we also have this advances in fetal medicine. And as you can see here, this is some data from UK. As you can see here, in nearly 600,000 women or 600,000 population, the younger age group is on the rise. In the younger age group, with life-limiting conditions, you can see that the amount of congenital abnormalities is on the rise. So what is life-threatening and what is life-limiting conditions? Life-threatening conditions are conditions where there can be a cure, but treatment may not be successful and the baby may die. And the pretext of this talk is the bulk of our fetal medicine, where there are conditions that we can diagnose and that cannot be cured, but there is an outcome. I mean, there may not be an option of termination of pregnancy, and the death in childhood is likely. If you look at survival data of preterm deliveries, so therefore early preterm deliveries that have got a high likelihood of residual abnormalities, you can see that the average percentage of increase of early preterms between 22 to 24 weeks is rising by 6% every year. And then, like the previous speaker, you've got the babies that have got congenital problems that are diagnosed, but they may not have had invasive testing in pregnancy. And when they are in the neonatal unit, you can see that if there is conditions that can be offered whole exome sequencing, the last line, about 65% of cases, or nearly 85% of babies, will be repatriated to palliative care. That means you won't be able to do anything about them. So this is a bulk of abnormalities, and in a situation, in the geographical situation like Egypt, where termination is not an option for non-lethal conditions or severely lethal conditions, this is where we step in to offer the kind of care or support to the families as we should. So what is perinatal palliative care? It is an active approach for care of children with life-limiting conditions, so that at the time of diagnosis, and you continue throughout the time that the child is born. Now, it will be planning for how the child should be when the delivery should happen, what should happen at the time with the neonatal team, the extent of resuscitation, and then the kind of care you should offer to the baby to make the baby supportive, to make the baby comfortable. And what is antenatal parallel planning? It is planning for the possibility of deterioration or death in the baby, while also making plans to make sure that you can offer active care. So it is doing things in parallel and not leaving it to the last minute. Because parents, once they know that there's an abnormality, there's a diagnosis, the grief starts there. So this is some work from the British Association of Palliative Care, Perinatal Medicine. I was one of the co-authors for this work. And this is an algorithm which is where you've got a survival-focused care. That means there's an abnormality and you do everything for the baby. And you may not be able to achieve the result. Or you have some babies that may survive, some babies that may not survive, and this is the bit that you get involved in. You involve the family, you understand what the family wants, what is the extent of resuscitation that the family wants, if the baby is surprisingly alive and which you were not expecting, what kind of symptom management and where should this baby go? And if the baby dies, are you going to offer bereavement support? So this is some work that we did in the UK with nearly 600,000 pregnancies, and this is from the Neonatal Registry of Database. Palliative care is divided into 4 categories, or the conditions that can be entitled to palliative care is divided into 4 categories. It's the first 3 categories that are involved, that we are involved as fetal medicine clinicians. So conditions that are not compatible with life at all, conditions that have got a high risk of abnormality, or babies that are born in the margins of viability. So in the interest of time, we'll just divide. So what are the kind of conditions? The ones that are not compatible with life at all, majority of them are either things like anencephaly, but predominantly in those 600,000 women, trisomy 18. This is the bread and butter of fetal medicine. All the severe end of complex cardiac defects, complex thoracic defects, oligohydramnios, anhydramnios because of renal defects. And then, of course, you've got the margins of viability. But this is the interesting data. Things that we thought, like trisomy 18 or anencephaly, that will not be able to survive. If you look at the data here, the category 1, at 1 year of age, 13% of babies were still alive. So, and those are the babies that were discharged from the neonatal unit. For category 2, this kind of data, 1 in 3 babies were still alive. So while us as fetal medicine physicians, pediatric surgeons, we all make the plan, we do things immediately around the delivery bit, afterwards, at 1 year of age, neonates are still, and parents are still dealing with these babies. So you should ask yourself a question. When you're a fetal medicine clinician or an obstetrician, you diagnose an abnormality, this is the surprise question, what we've called in the document. Would you be surprised if this baby had a bad outcome or this baby died? And if you are not surprised, then you should have an advanced care plan for this baby. And yes, that involves resources. You will need to have a team involving yourself with the neonates to talk about what kind of care you need to offer. And you need to have an acknowledgement of the uncertainty of diagnosis. You've diagnosed, but we don't know, especially for cardiac defects. You diagnose things, but after the baby is born, you don't know which way the baby is going to go. And putting your parents at that point to say, do you want us to do everything? Do you want us to restrain? that's not the right time. So what does an advanced care plan look like? We worked with the Liverpool team to devise this advanced care plan, which involves everything from when the baby should be born, when the neonates see, do you want active resuscitation? Do you want to see how the baby responds to initial resuscitation and then progress? Or do you want just comfort care? If the baby dies, what kind of bereavement support do you want? Do you want placental histology, genetics, postmortem, etc.? So this covers everything. And this plan is usually made in the antenatal period. So these are some key questions that we have recommended that you should ask your families. But at the end of the day, the hesitation to discuss palliative care we find from clinicians, because we as clinicians are not engineered to give up on babies, to give up on life. And we are not telling anyone to give up on life. We are not telling fetal medicine clinicians to give up on life. We cannot just wait and see how the baby is going to be at birth, and we are not letting the baby die. We are just making a parallel plan. So in the interest of time, just very quickly, what as obstetricians you should do for babies that do not have a good outcome or not destined to have a good outcome. You offer continuity of care. You make a decision about whether you're just going to allow the woman to labor. If she labors, what is the intrapartum setting? Are you going to monitor with the CTG? If she presents to you with reduced fetal movements or abnormal CTG, are you going to offer cesarean section? Usually the C-section will only be for maternal reasons. You should introduce them, if you have a bereavement team, introduce them to the bereavement team. And in our situation, we have hospices. And I acknowledge you may not have hospices. Not every place will have hospices. For delivery bit, it is important to still do a third trimester scan. And you may argue to say, why are we doing a third trimester scan if you're not doing anything to these babies? That's because we are not giving up on the baby. The baby still needs to be comfortable. Baby still needs pain relief. And for that, you need estimated fetal weight. And you should never compromise the maternal care. This is some work that we did with the perinatal hospices. In the UK, you've got children's hospices, and now they are trying to move very closely to getting into the perinatal region, which is the antenatal period, which is fetal medicine diagnosis. And as you can see here from the Liverpool hospices, the number of antenatal referrals are increasing. In London, we are not good. In London, only this little dark gray is antenatal referrals. Everything else is postnatal. But as expected, we have a range of abnormalities. The predominant kind of referrals that come from to the hospices are the ones that are the bread and butter of fetal medicine. This is some work that we are currently publishing. So what do hospices do? They do all of these things. Before I started doing this work, I had never been to a children's hospice. I just thought people go there and then they pass away. But it is that's why I said your city, your country respects the dead and departed. This is what hospices do as well. And what I learned was you can graduate from a hospice. So you go to the hospice, technically in quotes, you're signed off, things are not very good, and there are babies that surprise us and they are graduated and they go home because they haven't passed. This is a baby with Coffin-Cyrus syndrome. This is a lady who was referred because of a complex cardiac abnormality, significant growth restriction, absent corpus callosum, abnormal profile, clitoromegaly, and was born preterm. And this is the MDT discussion. This was a medic. And this is the MDT discussion with the pediatric surgical and the cardiac team. Because the question was, are we going to operate on this heart when this baby has got all of these abnormalities? The mother wanted the heart to be operated on. Mother did not want to accept parallel planning. And ultimately, they did not operate. The baby took a turn for the bad. Baby passed away after perinatal palliative care input, and this is just a vote of thanks from the mother a year after the baby's passing, acknowledging the input that she had, the support, the ongoing support that she had. And I acknowledge not everywhere it is possible. This is a case with the anhydramnios. You can see a distended bladder, dilated kidneys. The woman had had selective growth restriction in monochorionic twins the previous pregnancy, and she lost both the babies after a laser. So this pregnancy, she wanted everything. Despite counseling, she went for a shunt, then she went for a repeat shunt because she did not want to do anything, she did not want to accept that anything wrong can happen. So just because we are doing an active intervention didn't mean that we wouldn't give her the option to say, well, if your baby was born alive, which it did, what kind of specialist care can we offer you? And sometimes we offer, this is a baby with osteogenesis imperfecta, mother would not accept the diagnosis or parallel diagnosis, and she delivered and she did not want to see the baby. This is a baby with 2 failed NIPTs, only a small head, and at 3rd trimester ambiguous genitalia, an amniocentesis done, which was triploidy. She decided to continue. Baby was born. She went down the parallel planned route. At 29 weeks, developed mirror syndrome, and then baby was born demised. And this is anencephaly. We know and we look after anencephalies. You look after anencephalies. Parallel planning in twin pregnancy, this is complex because you are planning to deliver one baby, aiming to gain as much gestation as possible, but at the same time, you have to respect and you have to acknowledge that the other baby may not survive. So the first case was a a dichorionic twin with evolving hypoplasia of the right ventricle. The second one was an Epstein's. And we have to acknowledge that the grief in multiple pregnancy is much more or different from singleton pregnancies. It's not just the grief of one baby being alive, one baby dying, or preterm delivery, but it's also that they may never get pregnant with twins again. So I've put in the QR code. This is a holistic diagram of what kind of care or what kind of discussion we normally have in the perinatal palliative care framework. And this is the document that came out in June. This is a list of abnormalities that we have outlined in the document of the kind of conditions that, can we just have that slide please, so that if somebody wants to take a picture, they can. Thank you. So I had made a box of the abnormalities, so that's what is figured out in the BAPM document of the kind of abnormalities, and they are all on the severe end of the spectrum. And then the last thing, as I said, in low resource setting, I was speaking to Professor Karam earlier, it's understanding, it's listening to the woman, understanding what they want, them to understand what is the extent of care that we can provide, and then respecting their wishes. And some more resources. This is a very short talk, but some more resources if you wanted to go into it in a little bit more detail. Thank you.
Thank you, Dr. Nanda, for this excellent presentation. Always miss about this palliative care in fetal medicine. Let me introduce now Dr. Mahmoud Yahya, our great son and scientist in Great Britain. Welcome, Dr. Mahmoud. His topic will be selective fetal growth restriction in monochorionic diamniotic twin. So please, Dr. Mahmoud.
Thank you, Dr. Hassan, and thank you for the kind invitation from the ASOGIC team. We'll talk today about selective fetal growth restriction in monochorionic twins. Why selective growth restriction? It's very common in monochorionic twins, and it's one of the commonest complications from placental sharing. 10 to 15% will have reversed or absent EDF in the umbilical artery, and we will go through this in a minute. The risk factors for developing this condition is abnormal cord insertion, one of them, which is something we invariably see with the monochorionic placenta, or early in pregnancy if we see a significant crown rump discrepancy. Let's go straight into cases. So that's first pregnancy IVF, 39 years old, BMI 47, referred 20 weeks after anomaly scan. As you can see, this baby here has normal Dopplers. You can appreciate that the umbilical artery has raised PI here. Baby number 2 was small. As you can see, all the measurements are small, but liquor volume is normal and there is no evidence of TTTS. Twin number 2, on the other hand, normally grown with normal Dopplers. So the twin number 1 on the 3rd centile, that 2 on the 62nd, and you can appreciate there is 25% discordance between both babies. Dopplers remain normal, and the MCA is 0.2 and 0.1. So what do you think? Is this selective growth restriction, type 1, 2, 3, or there is any TAPS happening? So that's a type 1, but there is no TAPS because the moms are normal for both MCAs. So we did offer weekly scans, and we said those pregnancies are likely to continue and we can deliver later. It's not unusual for those pregnancies to continue until 34. The woman at 23 weeks came with very small baby. Twin number 1 was very small, less than the 1st centile. And twin number 2 continued to grow. As you can see, all the measurements for twin number 2 remains all right. So what would you do at this stage? The growth discrepancy has become very significant. What would you do at this stage? Would you offer selective termination for one baby? Would you offer laser or no interventions? Actually, we didn't offer any intervention, and we said we will continue at this stage since the Dopplers were normal until 30 weeks. As you can see here, twin number 1 started to have persistent reversed end diastolic flow, but the ductus remained normal. So at this stage, we said that's type 2 now with persistent reduced EDF. We admit the woman for steroids and delivered by cesarean section after Maxalf. First baby remained under the 1st centile after birth, and twin number 2 on the 25th centile. And this is the placenta, as you can see, and there is unequal placental share, which is typical for the selective growth restriction. Case number 2, spontaneous pregnancy, fit and healthy woman, previous section, MCDA referred at 15 weeks because of discrepancy in size. The first baby, as you can see, is normally grown. But the second baby is really small, less than the 1st centile. And these are the measurements, as you can see. Twin number 2 is extremely small with oligohydramnios. And when you look at the Dopplers as well, twin number 1 has normal Dopplers, but twin number 2 has intermittent, absent, reversed end diastolic flow in the umbilical artery, but still there is positive flow in the venous duct. So there is a 30% discordance, and the smaller twin has intermittent, absent, reversed end diastolic flow. What is your diagnosis at this stage? Given the fact we have intermittent, absent, reversed diastolic flow, so this is type 3 selective growth restriction. Again, we explained it's not unusual for those pregnancies to continue until 34 weeks without any intervention, but usually we would deliver early. There is risk of sudden fetal death with this type of selective growth restriction, with obviously a risk of up to 25% damage to the other twin. At this stage, would you offer any treatment? So we counseled the woman. We said if we continue without doing nothing, 50% chance there is double survival. But if we do some sort of intervention like radiofrequency or coagulation, there is risk of losing both twins, risk of losing larger twin after treatment, and risk obviously rupture membrane and preterm labor. The couple decided not to do anything. So we continue to monitor pregnancy. Baby is still very small, but marginally growing. But at this stage, the Doppler changed. So there is persistent end diastolic flow loss in the umbilical artery, and the DV wave is absent at this stage. We discussed again selective termination with bipolar coagulation, and the woman agreed. So we did selective fetal growth restriction of the smaller twin, and this is the forceps as you can see it by the ultrasound. We did follow up the other baby, continued to grow until 32 weeks when she had rupture membrane and ended up by an emergency cesarean section, and the baby is healthy. Had no brain damage. And again, this is the placenta. You can appreciate almost there is no placental part on the smaller twin, and there is a filamentous cord as well. So selective growth restriction is invariably because of unequal placental share. It does have a unique anastomosis in view of connecting both sides. You would get a lot of AA bidirectional anastomosis. And these, although they are protective, but they have significance, and we will discuss it in a minute. That's why you get the intermittent flow, as you can see, into the umbilical artery, because the blood keeps going back and forth into the vessel. According to the Delphi consensus, we can diagnose it as a single difference, one baby less than the third centile. That would be enough for diagnosis, or two of the other three, either a small baby with abnormal Dopplers or estimated fetal weight discordance more than 25%. The Kratakos classification is the traditional that is used for the selective growth restriction. Type 1 if there's EDF present, type 2 if there is persistent absent flow. Type 3 is the one with intermittent, which is a little bit interesting. It does have majority of AA into the placenta. And as you can see, the low number of AA, the more likely you get a compromised small twin. So suggested new classification by Khalil et al. Type 1 is the umbilical artery ADF present, and type 2 persistent or intermittent absent, but actually type 3 and type 4 introduced, and it started to look at the ductus flow or the death of one twin. How to differentiate? If you've got a small baby with oligohydramnios, is it TTS or it's not TTS? So the golden rule is always look at the liquor volume on both sex. A TTS is a poly-oligo sequence. You cannot have TTS without poly-oligo sequence. But if you have a normal and oligo, then this oligohydramnios is likely because this small baby is hypoperfused. So the outcome depends really on the gestational age of diagnosis. The earlier it happens, the less likely that they will continue the pregnancy without problem. Kratakos stage 3 has unexpected, obviously, fetal loss. Estimated fetal weight discordance more than 40% is very significant and carries risk for both twins. And the Dopplers of the smaller twin obviously carries significant prognosis, especially if the baby has really bad Dopplers early at diagnosis. Cord insertion, and we talk about cord insertion now. Cord insertion is almost always abnormal in selective growth restriction. You would want to see the cords away from each other, or an abnormal cord insertion like a filamentous or a marginal cord insertion. But if you see cords that are close together, is it a good thing or a bad thing? We will see in a minute. Expectant management is well known for this type of complication. You can follow these babies every week, and actually you don't need to see them every few days like the singleton. You arrange for fetal echoes, which is a routine practice anyway for monochorionic twins, but those babies are prone to problems in the heart. You follow up for TAPS or TTS, because the superimposed TTS or TAPS can happen on top of a small twin. You target the steroids and obviously the max salve, and deliver based on really whether the baby is growing or if there is abnormality in Dopplers. Active management, if you diagnose very early and there is a very significant growth discordance and you feel that this baby is very much likely to die, what do you want to do is most probably protect the other baby. So intervention is based on the fact that you are likely to get a demise on the smaller twin very soon. Selective feticide can be done either by laser, bipolar coagulation, radiofrequency ablation, and some group recently described microwave ablation as well. So the studies shared outcome with the either expectant laser management or selective reduction. Laser management until now did not really prove to be a favorable treatment for selective growth restriction. The selective reduction, as you can see by other coagulation or radiofrequency ablation, will have similar or comparable outcome in type 1. In type 2, you can see the selective reduction will carry slightly better outcome. And in type 3, there is comparable results both in selective reduction and expectant management. But you can see always that laser is falling behind. The Leiden group has published recently a very interesting article about the natural outcome of the 3 types, whether with TTS or no TTS, and you can clearly appreciate that obviously type 1 will have the higher survival rate and type 2 will have the lower survival rate. So what about the codes? So what would you say as an proximal chord? If both chords are less than 4 centimeters from each other, that's a proximal chord insertion for twins. Is it a good thing or a bad thing? It is a good thing and it is a bad thing. So it means if they are very close that they have a lot of AA anastomosis between them, this means the small baby is more likely to survive a little bit longer because it's feeding onto the other baby. So actually this baby is more or less protected by the other baby. However, it's a bit tricky when you follow up these patients. If you remember, we mentioned that a growth discordance of 25% or more is required for diagnosis. But actually you can miss some of those babies because they do have selective growth restriction and it's a pathology rather than a fetal size. So they can be small, but you might miss them because they keep growing on top of the other baby. So you might not have a significant growth discordance, but actually you get a compromised baby that will be complicated and you end up by losing both twins. So in our center, if the cord insertion is very close, we watch those babies starting from 15% growth discordance, and actually we treat them as selective growth restriction based on this. Thank you very much.
Thank you, Dr. Mahmoud, for a very comprehensive presentation. Next speaker will be introduced by Dr. Daya Al-Nashar.
I have the pleasure to introduce Professor Carlos Guin. He will present us with the role of pediatric surgeon in fetal therapy team.
Good afternoon, dear colleagues. Well, I'm a pediatric surgeon in an obstetrician and gynecology conference. So I have 15 minutes to convince you of why it's so important to have a pediatric surgeon in your fetal therapy groups. So let's go. Some general notions, you know all that, but this one very important. We have here 2 patients. We have the mother and the fetus, and we are going to take care in many cases of the fetus after birth. So for the fetal therapy, you know the criteria. We need to know an isolated malformation. This criteria has been discussed nowadays. A well-known natural history and proven benefits of the intervention. You know that. So for the evidence-based indications for fetal therapy, we can say that there are some monochorial gestation disorders. We had just had a wonderful lecture about that. Some malformative conditions, congenital diaphragmatic hernia, low urinary tract obstruction, pulmonary masses, etc., and neural tube defects, and evolving conditions like amniotic vein, hydrothorax, cervical masses, right? So what types of procedures can we offer to the babies? Open fetal surgery, fetoscopic surgery, can either be percutaneous or with the uterus exteriorized, sonographic guide procedures, and an exit procedure, you know it very well. So as you see, we have many systems in here and different organs and different malformations. So in the committee we have for fetal malformations, we have many different specialists involved. And that's what we call a fetal surgery unit, and that's what we call in the streets like village people. I like to think about that like that because we are very different one each other. So why is important to have a pediatric surgeon in the group? Because we know about embryology, and because we know about the natural history of very different malformations. We are skilled in open surgical procedures, and particularly in minimally invasive surgery in very small spaces and in very small babies. We have the responsibility to do the explorations of the airway, the treatment of the airway conditions and the digestive conditions by endoscopy as well. And we take care of most patients, of most of these patients after birth. In contrast, we are not much involved in the diagnosis and the intrauterine follow-up, and we have, in general, low knowledge in several conditions, in particular, monochorionic twins, cardiologic procedure, intrauterine complications, post-birth follow-up, at least in Europe. So the normal indications for a pediatric surgeon in a fetal surgery unit are CDH, of course, amniotic vaginal release, luto, exit procedures, masses in the thorax, sacrococcygeal teratoma debulking, fetoscopic or open surgery for neural tube defects, and in some rare cases, pericardial teratoma resection. But there are other indications, and I know that in the United States, several pediatric surgeons take care of the TTTS and other sonographic guided procedures. But it's not normal in Europe. So from all of these procedures and malformations, we are very involved in many of them, right? So I want to make some reflections, for instance, in the twin-to-twin transfusion syndrome. I have to say that we are familiar in working in small spaces full of fluid, and in particular in the urinary bladder. As pediatric surgeons, we are doing many procedures in the urinary bladder, so we are familiar and we like very much this kind of intervention, although in Europe, in particular in Spain, it's you, the obstetricians, that used to do this operation. For the congenital diaphragmatic hernias, you say, as you know, the diaphragm should be closed at week 7, week 8, and then the abdominal bowel goes into the abdomen. If the diaphragm is open, goes up and compress the contrapulmonar, the contralateral lung, impairing his development, leading to a pulmonary hypoplasia and pulmonary hypertension, which is a huge problem postnatally, you know. So the current strategy, the standard strategy, is we plug the trachea in week 26, 29, and 6, 7, 8 weeks later we take it out. This is the introduction of the balloon. It's a tracheoscopy, and you see here how we take the balloon out. And I want to let you know that we are very familiar of these kinds of tracheoscopies and tracheobronchoscopies postnatally for many, many conditions in a very difficult airways. And we are used as well to do some interventional surgery with the tracheoscopy and bronchoscopy. As you can see, this is a normal baby, a grown-up baby, with some stenosis in the subcricoid area and with the dilatation. This is our daily activity in the world. And then we take care of the diaphragmatic hernia itself in a very limited space, in very small babies. If we can, we do that thoracoscopically. So we are good at that. Okay, for the amniotic band release, it's the same. It's a mechanical progressive strangulation of a limb or whatever it takes the band, leading to edema, deformity, the amputation. We did an experimental model on that, and we developed some techniques to solve it. This is one of the first cases. We use the laser, but you can use small instruments like scissors and everything. We are familiar with this kind of interventions, and we like them very much. You can follow the intervention as well by ultrasound, like this case. And we take care of the patient afterwards. So for the low urinary tract obstruction, you know everything. It's an anatomical or functional anomaly that compromises the outflow of the urine through the urethra. It's a malformative spectrum. It starts with the megabladder, then go to the hydronephrosis, kidney damage. And there are several causes. The most frequent cause is the posterior urethral valves. And unfortunately, only a little number of these patients are suitable for fetal treatment. When we have still a good renal function. And the two main interventions that we can offer is the vesicominotic shunt and the fetal cystoscopy. The vesicominotic shunt, normally in my media, is the obstetricians, the FMF, who do that. But we can help with the fetal cystoscopy for the same reason, because we are very used to work inside the urinary bladder. The difference is that you go from upwards and not downwards than usually. In a sense, it's in a small space, and we like it very much, but of course we have some complications. So for the congenital pulmonary airway malformations, which I had the talk yesterday, we can offer our experience for the open fetal surgery, or like in this case, for the exit to resection surgery. And this is why we take care of these malformations after birth. We like to operate on them if we can wait from month 3 to month 9. And this is what we do. We know the anatomy, we know where the vessels are. There are normally we use 3mm instruments, 2mm instruments. No, this is the vein, these are the arteries. Excuse me. And these are the bronchus. So we know how to do that as fast as possible if it's necessary during the prenatal life. The same with the sequestrations. We know how they evolve, when to operate them. We like to do that in a minimal invasive way. This is very seldom that you need to do anything interventional prenatally for sequestration, but in case we do, we know exactly what we're talking about. For the exit procedure as well, we can use several techniques to control the airway, as I talked about that yesterday. We have many difficulties and challenging cases, but we are experts in leading with the airway, and we are doing tracheostomies as well in our daily activity. So I think we are very prepared to do that. But we were born for that, for the neural tube defects. When you are using a standard open fetal surgery, maybe the neurosurgeon is the best prepared person to do that. But if you go to the minimally invasive surgery, that's another thing. So we are used to work in a very small spaces with very small patients, like for an esophageal atresia, duodenal atresia, anorectal malformation, pylorus, surgery of the biliary tract. So we are used to this kind of tissues, this kind of material, and we have real fun to do that as accurate as possible. This is a myelomeningocell surgery, and you can see how we free the plaque from the surrounding tissue, and we prepare the patient to close the myofascial layer, and you can see it's not much different than the closure of a diaphragm. It's more or less the same. Smaller instruments, smaller threads, but anyway, it's the same. So we do in a good conditions. We do in 2 layers: the muscular myofascial flap, myofascial layer, and then the skin, and voila. So to summarize, which are the uses of a pediatric surgeon? we can contribute to the knowledge on embryology and the natural course of these malformations. And this is good for the discussion of the cases, the diagnosis, and we can counsel the parents on some of these malformations because we know what's happening with a cloacal malformation afterwards, or what's happening with a CPAM, or what's happening with a CDH. And we can help with endoscopic procedures, as I told you, in the airway and the bladder. And we can deal with the airway control and exit procedures as well. We can offer surgical treatment for open fetal surgery and exit procedures. And of course, we can offer high-quality surgical treatment in complex fetoscopic procedures. So only one last take-home message. Please embrace a pediatric surgeon in your life. Please. Thank you.
Thank you, Professor Carlos, for the interesting talk. Next, we move to our colleague, Professor Dr. Ayman Shaban, USA, Cleveland, Chicago Institute for Fetal Health. And the topic we'll be talking about perinatal and long-term neurosurgical outcomes of fetoscopic spinal repair.
Thank you, and good afternoon. And thank you, Dr. Guinée, for the introduction for these talks. A little bit redundant, but I think hopefully a little bit more in depth for our interest. So the promise of in utero repair for spina bifida is that coverage in utero will preserve neurologic function for the baby, and their outcomes for postnatal care will be facilitated by the procedure that was done in utero because the potential for neurologic recovery is greater. The idea that perhaps repair here in the lower lumbosacral spine of the defect will allow recovery and preservation of motor function in the legs, but also improve the CNS changes that occur with spina bifida, the hindbrain herniation and the hydrocephalus. And this was tested in the clinical trial called the MOMS trial, was done in 2011, and showed us that, and it was published after about 10 years of research, showed us that the outcomes were better for the babies who had prenatal surgery, that the rate of cerebral spinal fluid shunting due to the hydrocephalus was cut in half at 1 year of age, and the rate of independent ambulation at 2.5 years of age was doubled in the group that had prenatal surgery. Hindbrain herniation improved in almost every patient, but there's also a higher rate of maternal and newborn complications. This is the operation as it was done in the MOMS trial. It was an open hysterotomy, essentially a classical hysterotomy. It's bloodless, it's well controlled, it's an elegant operation, allows good exposure of the fetus for repair by the neurosurgeon, a layered closure of the defect, and then a closure of the skin. And the babies would do well and benefited greatly from this procedure. But the problem with this procedure done open is that it has a high cost for a mother. And about half of the patients that we see are prima gravida mothers, and they'll go on to subsequent pregnancies. But because of this large hysterotomy that they have, no matter how well we close it, vaginal delivery is not permitted. Their risk for accreta and percreta go up significantly with subsequent cesarean deliveries. And there's a 2-year waiting period that we recommend before the next pregnancy. None of the patients will listen to us. As a result, the uterine rupture rate is as high as almost 10%, somewhere between 5 and 10% for subsequent pregnancies, typically carrying a pregnancy in the 3rd trimester, and suddenly the mother presents with pain, hypotension, and is rushed to the operating room with a risk to her life and to the fetus. So as we transition to fetoscopic spina bifida repair, our goals were to improve the outcomes for the mother. but fetoscopic spina bifida repair has had some challenges in the last decade. There's been a concern for fetal acidosis because of the exposure to the fetus to CO2, also because of compression of the placenta and reduction in perfusion of the fetus. There are various approaches for fetoscopic spina bifida repair, ranging from glue and a patch to a single layer of closure to other types of techniques. All of these have technical limitations due to the limitations of the size and the access to the fetus. And most of these procedures have been complicated by CSF leaks and reoperations, things that none of us would want to see with any type of surgery. Most importantly, there's no long-term outcome for most of these cases. So as we transition from open operation to fetoscopic surgery, we decided we'd perform the approach using a laparotomy-assisted technique that allows us to keep our pressure very low, to limit the amount of pressure and compromise of the fetal perfusion. We used a 3-port, 3-layer closure to emulate exactly what we do in open fetal surgery and what we do in postnatal surgery. Closure of the placode, closure of the dura, and closure of the skin and subcutaneous tissues in sequence. The goal is to reduce maternal morbidity, allow vaginal delivery, reduce uterine rupture, less accreta, less percreta, reduce prematurity, hopefully, and to have at least similar neurosurgical outcomes to the open procedure. So here's a view into a case here. This is an L3 spina bifida. Here it's myeloschisis. This, you can see, is taking advantage of the magnification of the laparoscopy here. You can see it very closely and very precisely, all the layers. The person who's operating here is a pediatric neurosurgeon who's now a fetal neurosurgeon. This individual had no experience in laparoscopy or minimally invasive surgery until she joined our program. And after a lot of training on the bench, in the animals facility, eventually working together with her, she's able to sew and do fetal neurosurgery in a way that we would call true neurosurgery. You can see the tubularization of the placode very nicely. She's taking care to avoid injury to the nerve roots. Here is the mobilization of the dura. And there's a fascial release as well to allow better closure of the dura. You can see a very nice dural tissue here for closure. And now she's sewing the dura, excluding the muscle, the fascia, excluding the skin, using a 6-0 proline suture with the fine cardiac surgery needle. And then mobilization of the skin and subcutaneous tissues. Very large myeloschisis defect still. We are able to close it primarily using a horizontal mattress suture. We do our best to avoid using patches of any sort, only organic or native tissue. Most of the synthetic patches that are used are made from cellulose or other different materials, and they're highly immunogenic, and they can complicate cord tethering and other inflammatory processes. So we have about 50 cases that we have performed here and have data for. We compare them to the MOMS trial data, looking at the demographics, essentially the same profile for the patients, for the mothers. Now, comparing outcomes of pregnancy outcomes, the mean gestational age at delivery was very similar, 34 weeks, as you can see, for both the moms and the fetoscopic group as well. We still have a problem with early delivery before 30 weeks. This group of patients creates the most morbidity for the newborns. But the majority of patients here, you can see right here, the big win is that all of the patients, essentially all of them, are able to have delivery by maternal indications. 60% of them had vaginal delivery, 40%, 20 of these patients had a cesarean. All except one patient were indicated cesareans. This is a big win for the mother immediately as a result of this procedure. Now, the price is a very long operation. These operations are technical, and they require about 3 hours of surgery just in the fetal back and a long operative time. The rate of intraoperative fetal bradycardia and neonatal and uterine demise are quite low. Again, most importantly, the rate of maternal complications is very low. We're very proud. Very low rate of intraoperative hemorrhage, I guess 0, and some significant pulmonary edema is very unlikely. Abruption, preeclampsia, and hypertension really no different from the mom's trial at all. And again, no issues with the wound or with healing at the site. Outcomes, technical outcomes for the baby, they're listed here. We were able to perform three-layer closure in 71% of the patients. The majority of patients had imbrication of the placode. 94% of the patients had primary dural closure, no patches, and 75% of the patients had primary skin closure. And we're getting more and more aggressive with skin closure with the horizontal mattress approach, and essentially are going to eliminate that altogether. We've had very few wound complications, no CSF leaks, and very few issues with the skin. Also importantly for the fetus is the improvement in the hindbrain herniation. You can see here on the left here, the fetus preoperatively at 23 weeks on the MRI. You can see the significant crowding in the posterior fossa and herniation of the cerebellum into the spinal canal, the grade 3 type 2 Chiari malformation. And then the same patient, a few weeks postoperatively, you can see the normalization of the hindbrain, the cerebellum, the fourth ventricle, flattening a little bit of the tentorium, and the resolution completely of the herniation, all in a few weeks. And the majority of patients experience this. Complete resolution from a grade 3 or 2 to a grade 1 in 86% of the patients. Moderate resolution from a grade 3 to a grade 2 in about 12% of the patient. Only one patient with no change. So 98% of the patients had improvement in hindbrain herniation as a result of the procedure. Again, looking at postnatal wound complications are listed here. CSF leak, pseudomeningoceles, and wound dehiscence. Comparing our open series to our fetoscopic series, no incidence of CSF leak, no reoperations for leak, but we did have some skin dehiscence, some skin patches that did not heal well, that required an operation postnatally, and one here that required dressing changes that healed well, but no CSF leaks, really tight seals in all the patient. Motor function, very important. You can see here, this is describing open fetal surgery, fetoscopic and postnatal at the thoracic, upper lumbar, mid lumbar, lower lumbar, and sacral levels for all of these. The anatomic level here is described in the white, and then the functional level, which is then examined after birth, here is in the black. And as you can see, for open and fetoscopic, a shift towards the right to more lower lumbar and sacral levels than would be predicted by the anatomic level for fetoscopic. Only a handful of patients thus far. For postnatal, there was no shift. All of the patients really similar in terms of their profile of thoracic and upper lumbar compared to sacral ratios. We've had hydrocephalus checks on about 32 of the patients from the fetoscopic group, and you can see here hydrocephalus is reduced in either open fetal surgery or fetoscopic compared to postnatal. Tethered cord releases, there's been a little bit less fetoscopic tethered cord release issues in the fetoscopic, but in general very similar across the board. In Chiari decompression, here we haven't had any Chiari decompressions in fetoscopic, but one in the open fetal and a couple in the postnatal contemporary group as well. Dermoid formation has been an issue for a little bit more so for open fetal surgery and fetoscopic compared to postnatal. And I'll show you here, you can see this dermoid operation here that the surgeon's removing the dermoid capsule, including the contents. But the trend is a little bit higher rate for the fetoscopic and open. Nonetheless, the difference still at this point in time is not significant. Essentially, it's critical for all patients to have multidisciplinary care and follow-up. Multidisciplinary care because the fetal surgery is not a cure for this disease, it's a treatment, and the care after birth, the multidisciplinary care is essential for this child to have a successful life and as successful as possible. So to summarize, for fetoscopic spinal bifida repair, it's safe for mom, it's safe for the baby, that we've confirmed. It allows delivery by obstetrical indications. We're improving our outcomes with regard to latency and PPROM. The preliminary neurosurgical outcomes are to follow on the next slide. And we also obviously need a multi-center study in order to be able to standardize our approaches. The neurosurgical outcomes, we see similar back outcomes or closure outcomes for open and fetoscopic. There was a couple of skin revisions that were required for the fetoscopic, but no CSF leaks. Similar neurological or neurosurgical outcomes, less hydrocephalus, improvements in Chiari, improvements in the motor function. Tethered cord risk is about the same for the 3 procedures, either postnatal or fetoscopic or open. Dermoid appears to be trending towards a higher rate in the prenatal procedures. Hydromyelia is no different. Critically, again, maintaining optimal neurological function really requires multidisciplinary care and follow-up. It's just the beginning. I'd like to thank my team in Chicago. They're all here. It's a beautiful team. This is our motto, teamwork makes the dream work. I'd also like to thank our team here in Cairo, our new team, and really appreciate the invitation to come back this year and look forward to working with you going forward. Thank you for your attention.
Thank you, Dr. Ayman Shaban, for presenting this. Thank you, Dr. Ayman Shaban, for presenting these advanced procedures. Next speaker, Dr. Patricia Caldas, is going to present conotruncal abnormalities.
Okay, good afternoon. First, I would like to thank the committee for this kind of invitation. I'm really honored to be today. Unlike my previous talk, I am not a superhero. I don't do fancy operations. I'm a pediatric cardiologist. My specialty is imaging, and I would like to think that by identifying heart problems, we're saving babies' lives as well. So we're going to talk about conotruncal abnormalities. There are lots of them. Lots to talk about. We're going to talk about TGA, tetralogy Fallot, pulmonary atresia, dwarf, and truncus. So because I'm an imaging consultant, I'm going to show basically how we diagnose them and how we counsel these patients. So transposition of the great arteries is not uncommon. It corresponds to 5% of all congenital heart problems. And in TGA, what is happening is that you have the left ventricle connected to the pulmonary artery. So the great arteries are in the wrong place. That means this lesion is not compatible with life unless we do an operation. But the surgical results are really good, and the outcome is excellent if we diagnose it and make sure the baby is delivered in a surgical center. Fortunately for these patients, there is rare association with genetic and extracardiac problems. That's important for the counseling. Although we do offer amniocentesis if the patients wish, but I tell them that the chances of finding something are really low, around 1%. But again, it's a maternal option. We call transposition simple TGA when there is TGA with no other abnormalities. There's nothing simple about a TGA, obviously, but we call it simple because everything else is fine. The most common abnormality in TGA is a VSD, so a hole between the ventricles, and the size of the hole is going to be really important for the counseling. If it's big, it's going to be an issue because my surgeons are going to do a late operation. If it's small, it doesn't matter, so they can have a neonatal operation in the first days of life. Then we can have TGAs with pulmonary stenosis, which are very tricky to manage, and then we can see TGA in settings of more complex heart problems. So the problem of TGA is that we miss them. And the reason why we miss them is this. So if you look at the left, the 4-chamber view of the fetus is completely normal. You can see balanced ventricles, the crux of the heart is intact, and it looks normal. But if you look now, this is a sweep from the posterior part to the anterior part of the heart. And if you look, the left ventricle is connected to a bifurcating artery, which is the pulmonary artery. And again, looking at the left, this is why we miss it, because unless you look at the great arteries, which one is coming first, and it should be the aorta, you will miss it. So there are other clues as well. Usually in a normal heart, if you draw a line between the left ventricle and the aorta, it would be pointing to the right side of the fetus, to the right shoulder. And in TGA, because this is not the aorta, it's just pointing to the posterior part of the fetus. And then, fortunately, the 3VT, so the trachea vessel view, is abnormal. Most of the times, there are always exceptions in medicine, but most of the times, you can only see 2 vessels in the 3VT view, which is a clue, so that's good. And you will also see parallel great arteries, which are always abnormal in a heart. The great arteries, they do cross over, so you cannot see parallel great arteries. So my role as a pediatric cardiologist and fetal cardiologist is identify the problem, counsel the parents, refer to fetal medicine for discussion of pregnancy options. But my role is also this. There is a very small group of patients that will have a very tiny foraminal valley. So this flash you can see here, it's the flow across the foraminal valley. The foraminal valley is going to be really important postnatally for mixing of deoxygenated and oxygenated blood. And one of my missions, and I do that last appointment at 36 weeks, is to identify these high-risk babies. Because if there is not much flow across the foraminal valley, the baby is going to be hypoxic and will collapse immediately after birth. And this is the baby after birth, same baby. And you can see this flash here is the tiny flow across foraminal valley. So this baby was very hypoxic, but we had an interventional cardiologist close to the baby that did a septostomy immediately after birth. So the role of the fetal cardiologist is counseling, diagnosis, but also identifying high-risk patients so that we can work alongside neonatologists and interventional cardiologists. This baby had a septostomy. Immediately after the septostomy, he was pink and fine. But again, we need to identify these patients. So TGA, the prenatal diagnosis is difficult because the fourth chamber is normal. These babies need to be delivered in a surgical center. We start them on prostacyclin after birth, and most of the times they will need a septostomy, usually not in day 1 of life, but we end up doing eventually a septostomy. And in my center, we do an atrial switch operation between day 5 and day 10 of life, if the baby has a good weight. The mortality for this surgery in the United Kingdom is 2%. Which is excellent, considering we're talking about a major operation. So the outcomes are fantastic, but we need to diagnose this. Now, tetralogy of Fallot is also not uncommon. It's the most common cyanotic heart problem. Unlike TGA, tetralogy of Fallot is associated with significant genetic abnormalities, and this number can vary according to the subtype of tetralogy of Fallot. Can be associated with charge and Vactral as well. And in tetralogy of Fallot, the problem is that there is VSD, the aorta is overriding VSD, and there are several degrees of obstruction across the pulmonary valve. That could be below the valve, above the valve, and the valve itself is small. So some patients will have right aortic arch, which raises the risk of chromosomal abnormalities. And there is a very wide spectrum between mild obstruction and the extreme form, which is pulmonary atresia. So it can be associated with complete AVSD, which is a problem because it's more difficult for the surgeons to repair it. And this is, again, like TGA. The problem of tetralogy of Fallot is that if you do a 4-chamber view, it looks okay. This is a fetus with tetralogy of Fallot. Look at the ventricles, they're nicely balanced. The crux of the heart is intact. And you can only see a glimpse of the VSD, but if you just do a view of the 4 chambers, and if you don't sweep anteriorly, you don't see the VSD, so the 4th chamber is normal. And now if you look at the right, you can see the diagnosis here. You can see that, so this is the left ventricle, this is the septum, the aorta is overriding VSD, And at the end of this sweep, you can see the pulmonary artery is small. But again, if you just look at the left, you would say it's normal. Right, so there is also anterior deviation of the infundibulous septum, which is this chunk of muscle we see here and underneath the pulmonary valve, but actually in real life this is very difficult to see prenatally. So this is something I would see very easily postnatally. And here in the left we have the color Doppler. Oh, sorry, it wasn't playing. So in terms of 3VT view, you can have all sorts of things. You can have, can you just go? Sorry, it's not playing my video. But the 3VT view could be very different. You can have a right aortic arch with a right subclavian artery. You can have a right aortic arch with a left duct. And you can have retrograde flow at the duct. The retrograde flow at the duct is really important because this is how I decide which are the patients that I'll be worried with. And if there is retrograde flow at the duct, for me, I'm worried. This patient needs to be delivered in a surgical center and I will start them on Proston. And this is, again, the assessment of the flow across the duct. I usually do it throughout pregnancy, but my last decision is done at 32 weeks. And again, I'm trying to identify the patients that will need neonatal operation. So there are variants for tetralogy fallow. This is rare and actually very complicated. This is called tetralogy fallow with absent pulmonary valve. It's not a great name because the pulmonary valve is not absent. It does exist, but the leaflets of the valve are very rudimentary. That means these patients are going to have a combination of obstruction and regurgitation. And this is what we see here in the left. This pink flow here is blood coming backwards from the pulmonary artery to the right ventricle. This is the right ventricle dilated with poor function. And this picture here is the pulmonary arteries. I have received this patient actually referred by a colleague that said that actually this patient had a cystic lesion in the lungs and actually it wasn't. It was just the cross-sectional imaging of the pulmonary arteries. So babies with tetralogy fallow, they do really well in fetal life. They don't die. I'm just talking about the heart, obviously. But unfortunately, this variant is a problem because they can develop heart failure and actually this baby didn't survive. So it's an exception because most of the babies do well in fetal life. With most of the cardiac problems, not these ones, they can die in fetal life. Not apologize. Okay. So tetralogy fallow can also be associated with Down syndrome, with AVSD, and that makes the diagnosis even more complicated because then we have to ask the cardiac surgeon to repair tetralogy fallow plus AVSD. So the surgical repair is a bit tricky. It doesn't change in terms of mortality, but it becomes a bit more tricky for the surgeons. And there is a very significant association with Down syndrome. We know that 75% of the patients could have Downs as well. So how do we manage these patients? It really depends how tight the pulmonary artery is. If there is significant pulmonary stenosis, they need to deliver in a local, in a surgical center, and we'll have to plan for neonatal palliation that could be either a stent or a BT shunt. The other ones that are stable, they go home and we do an operation at 6 months of life with mortalities of 2%. The prognosis is excellent, although they will need further surgery throughout life. Now, the most extreme form of the tetralogy fallow is this one, and this is one of the most challenging cases for us fetal cardiologists because all the parents want to know, is my baby going to be fine? And I find very difficult to tell them if the baby is going to be fine because there is so much variation in terms of the anatomy that it's really difficult to predict the future here. So in these cases, there's also a VSD with overriding aorta, but there's no connection between the heart and the pulmonary artery. And these patients will have abnormal vessels coming from the aorta supplying the lungs. We call them MAPCAs. And depending on the number of MAPCAs, how many they are, where they come from, these babies will have very different prognosis and management. So that's why probably this is one of the most frustrating situations in fetal cardiology because we are not very good in terms of prognosis. Oops. This is not working again. So this is called the extreme form of tetralogy fallow or pulmonary atresia with VSD. There is very strong association with extracardiac problems, and these patients need to be delivered in a surgical center. And it looks in this view here, this is a patient with pulmonary atresia, VSD. The aorta is overriding the VSD. So it looks exactly like a classic tetralogy fallow, but actually there is no connection between the pulmonary artery and the lungs. So the pulmonary artery is completely blocked. I apologize, but this is not easy to... And this is again the same view, and actually this patient, the prognosis is really poor. So this looks like a tetralogy fallow, but at the end of this sweep, you can see the pulmonary artery is almost impossible to see, it's almost non-existent. So the prognosis is very poor, and this patient did not survive because the surgeons can do many things. They can close hole in the heart, they can do lots of fancy surgery, but they cannot enlarge a pulmonary artery beyond the hilum actually. So there's nothing they can do about this one. These patients actually will end up having a CT scan for management. I'm not going to talk about DORV because I don't have much time. I will just show you the last one, which is truncus arteriosus, which is quite rare. It's less than 1% of all congenital heart diseases. Usually there is no duct. And there is common origin of the aorta, pulmonary artery, and coronary arteries. And there is a very strong association with 22q11 deletion, and usually, and almost 40% of patients will have also right aortic arch as well. So the problem in truncus is... Okay, there are several types of truncus. Doesn't make much difference. There are no cardiac surgeons here, so I think I can say this. It doesn't make much difference, but I think what makes much difference here, it's this. And I'll show it in a second. There we go. So the key for a truncus is this. This is going to make the difference of having poor prognosis, good prognosis. It's the truncal valve. The truncal valve is usually abnormal, but if there is mild narrowing and regurgitation, I think that's fine. The surgeons won't have to do much. But look at this valve. This is two ventricles, VSD, the truncus is overriding, and all this blood is going backwards. So there is significant regurgitation of the valve. So this is a complete disaster in terms of, this baby didn't die, but didn't do well postnatally. And I'm just going to show you the last one, if I may, which is this one. This is the future of fetal cardiology, which is meaning that I will be out of job. This is fetal MRI, okay? And this is a patient with a truncus with a duct and end up having a fetal MRI. And I think moving forwards, I think that will probably be the future of fetal cardiology imaging. Thank you for your time.
Thank you very much, Dr. Patricia. دلوقتي جه وقتنا على النوفو نورديسك سيمبوزيوم. دكتور محمد سيد علي موجود؟ كويس. هيتكلم على recognizing females with rare bleeding disorders. بروفيسور محمد سيد علي.
Hello everyone, and sorry for the time lag. We hope all the attendants will be amused by the lectures, and thanks for the chairperson. I want to start by thanking Novo Nordisk for sponsoring this session. We especially thank Dr. Abdurrahman and Dr. Walid Muharram for sponsoring this session. We are going to talk about a very interesting entity of female bleeding, which is recognized female with bleeding disorder. To talk about heavy menstrual bleeding, we define it as more than 80 milli per menstrual period. Sometimes the patient came with different complaint, maybe bleeding last more than 7 days, or changing multiple sanitary bed, or requiring double protection. Also, sometimes there is passage of large blood clots. The estimation of the problem is around 9 to 14% of whole female population. Up to 20% of these ladies having a problem of bleeding disorder or inherited bleeding disorder. Heavy menstrual bleeding can adversely affect the quality of life of the female. Sometimes the problem leads to anemia, hospitalization, limitation of the daily activity, and adverse psychosocial effects. And of course, sometimes she needs surgical intervention. Again, many methods to assess the amount of bleeding, and this is the most difficult. If you have a patient with heavy menstrual bleeding or young female or adolescent girl, the estimation of blood loss is the most important issue, because as a doctor, as clinician, we have a debate. Is this heavy bleeding or no? And sometimes we don't believe in that except when we find hemoglobin drop to 7 or 6. Classification of heavy menstrual bleeding have different issues. Maybe age classification, time classification, cyclic versus non-cyclic, etiological classification, and the most important is the systemic cause or inherited cause. FIGO classification system, this is palm coin for abnormal uterine bleeding in non-gravid women of reproductive age. As we see, we will find that they define palm as polyp, adenomyosis, leiomyoma, malignancy or hyperplasia, and of course other problems. The other way is the palm, is the coin, which stands for coagulopathy, ovulatory dysfunction, endometrial troubles, iatrogenic complication, and unclassified. The International Society of Thrombosis and Hemostasis in 2013 defined the bleeding tendency as a practical guide useful for documenting bleeding system. 14 items to assess the score. As we see, sometimes patients present not by heavy menstrual bleeding, by bruises, contusion, bleeding per gums, or subcutaneous hemorrhage. The score is made of 14 items, as we will see. Normal range is 4, above 6, and in children around 3. So there is age difference between the score. What we are interested as clinician, the symptom. If the patient presents by epistaxis, cutaneous hemorrhage, bleeding from minor wound, oral bleeding during gum chewing or brushing, GIT bleeding, hematuria, and sometimes start by heavy bleeding after tooth extraction. Of course, these patients are more prone for menorrhagia and hemorrhage during surgery. The American Society of Obstetric Gynecology and the ISHRI guidelines about hemorrhage still debatable about how to manage this case. If we start to talk about the coagulopathy, we find that the inherited disorder of bleeding, the most common and the most important is von Willebrand disease, which present around 61% of the causes of bleeding in female. Second most common is the inherited congenital coagulation factor deficiency. As we all know, maybe factor 2, 7, 5, this is the commonest, maybe other factor. Sometimes the problem with the platelet itself, like Lanzmann thrombocythemia and Bernard-Soulier syndrome. Hemophilia also is another important factor of bleeding. Large population of women report heavy menstrual bleeding. We have to search for these cases and we have to treat them effectively and properly. Maybe gynecological symptom may be the first complaint and maybe the life-threatening hemorrhage every menstrual cycle. Von Willebrand disease is the most relevant as we talk. The second is hemophilia A, hemophilia B carrier, rare factor deficiency like factor 7 and platelet deficiency, Glanzmann thrombosine. What are we going to do if we have a von Willebrand disease? The patient came to the clinician with heavy bleeding, anemia. We can start by desmopressin. Also, we have von Willebrand factor infusion. Sometimes we need antifibrinolytic, and of course, most of these cases become well controlled on birth control pills. Combined estrogen and progesterone will be very effective. What about Glanzmann thrombosine? It is a rare autosomal recessive coagulation disorder. Patient commonly affected both men and women. Genetic defect is located on chromosome 17. The incidence is 1 per million, especially in consanguineous marriage. This is characterized by quantitative and qualitative defect of the platelets, impaired platelet aggregation, and wide range of clinical phenotypes. Heavy menstrual bleeding, of course, is life-annoying and may be critical. Clinical severity depends on a clinical basis and not biological classification. Menorrhagia may be severe enough to need transfusion, and this transfusion is commonly recurrent. Bleeding manifestation from large case series, most commonly present by epistaxis, may be menorrhagia, berbera, and sometimes CNS hemorrhage, and the patient may have stroke. We have nowadays platelet aggregation profile, and we can do tests for platelet aggregation, and we can do flow cytometry to detect the platelet defects. The overview for therapy: either your patient needs only conservative treatment and local measures. Sometimes we have to go for platelet transfusion with the risk of blood and blood product transfusion problem, and sometimes we go for recombinant factor 7, which is the most effective. So, as a conservative treatment for any patient with inherited bleeding tendency, we do pressure maybe for nasal epistaxis. Sometimes we run for local hemostatic antifibrinolytic, as we say before, may be very effective. The platelet transfusion is the standard treatment for severe life-threatening bleeding. Sometimes we need intervention in these cases. There is risk of alloimmunization and antibody production, which may later on be dangerous, because if this patient has surgery, she may bleed to death. We may require hospitalization, and different type of platelet preparation now available to manage these cases which have alloimmunization and to decrease risk of bleeding. Recombinant factor 7 is the golden solution and the golden rule in these cases, because it represents alternative therapy to patients with past or present refractory platelet deficiency. It is the alternative to human plasma. The recommended dose depends on the patient condition. 90 microgram per kilogram is the average. Of course, we'll not go much for physiology, but the most important that recombinant factor 7 activates thrombin. Thrombin generation will invite platelet. Platelet will be activated. Platelet mesh together with fibrinogen shift to fibrin. This make fibrin aggregation with the platelet, and clot stops the bleeding. Again, recombinant factor 7 is effective in controlling this patient, and it is around estimated 80 to 97% efficacy in this case. So the results support that the use of recombinant 7, factor 7, is suitable alternative treatment option in heavy menstrual bleeding in patients with Glanzmann thrombocytopenia. Of course, the condition may be since birth, the children may have arthrogryposis, bleeding from gums, and all this can be prevented by recombinant factor 7. Last but not least is factor 7 deficiency. The patient may have factor 7 deficiency, which may cause the same as we say, bleeding and heavy menstrual bleeding, life-threatening. What we are interested that the most common rare congenital coagulation is factor 7. Other factors are more or less very rare. So abnormal hemostasis in congenital factor 7 deficiency, as we see, factor 7 make complexes not formed, so the patient have reduced thrombin formation, impaired platelet aggregation, and bleeding. Commonly, the symptom of factor 7 deficiency is epistaxis, oral bleeding, cutaneous, subcutaneous hemorrhage, menorrhagia in female. As we see, this is the commonest presentation, and the dangerous is CNS hemorrhage. Severe bleeding may occur, and according to the phenotype, we can divide this patient. CNS and GIT bleeding episode may be life-threatening and fatal. Conventional therapy by fresh frozen plasma have a role, of course, but still many debate about the complication, fluid overload, transfusion-associated reaction. Prothrombin complex concentration also can be given for these cases, and of course plasma-derived factor 7 can be given. All derived from blood have the risk of transfusion-transmitted infection. Recombinant factor 7 represent the gold treatment in these cases, represent the optimal factor for replacement, manufactured using recombinant technique, and the concentration will be kept above 25,000 international units. Mechanism of action, as we all know, recombinant factor 7 work on thrombin directly, activate platelets in presence of factor 5, factor 10, factor 8, thrombin, invite platelet aggregation, and make hemostatic blood. In hemophilia also, we can manage these cases by recombinant factor 7, especially hemophilia A, B, and C. So, indication and dose, don't forget the recommended dose in factor 7 deficiency, 15 to 30 microgram per kilogram given every 4 to 6 hours till hemostasis, and the dose and frequency should be adapted for each individual. Here is the dose, and here is the formula available in Egypt. Lastly, we can say that heavy menstrual bleeding due to factor 7 deficiency should be managed properly, and tranexamic acid is an important role. This is the STEER registry, says that the same, we need recombinant factor 7. Our take-home message, acquired and inherited bleeding tendency is rare but dangerous and an important cause of heavy menstrual bleeding. Von Willebrand syndrome is the commonest type of adolescent and young female presented to your clinic having heavy menstrual bleeding. In inherited factor 7 deficiency, single dose of Nova 7 every 6 hours may be enough to control life-threatening bleeding, and the dose vary according to the weight and may require more doses if not controlled. Thank you very much.